Good evening, everyone. My name is Bob Christensen, and I am the moderator for tonight's webinar on updates for the CMTA strategy to accelerate research, commonly referred to as STAR. I'm hoping you all know what STAR is, but if not, in a moment our presenters will give you the details along with updates on the latest research advances that can possibly be used to form treatments for CMT. I've had CMT my entire life, CMTIX for those keeping track, and I'm a proud supporter of the CMTA and honored and excited to be part of tonight's webinar. In my opinion, there's no way you can come out of tonight's webinar feeling anything less than inspired, thankful for all the work being done, and motivated to support this effort. However, understand that none of this happens without your help. The presenters tonight and all of their colleagues, and there are many who work so hard for this CMT community, really do deserve our support. And today is Giving Tuesday, and I would encourage all of you to make the CMTA your choice for Giving Tuesday donations. You can simply go to the link at the bottom of the screen here that you see. By the way, it's not an active link, so you have to either manually type it or take a screen capture of it so you can get to it later. www.cmtausa.org/we-are-family, that's we-r-family, and select the Match My Type gift link that matches your type of CMT. It's that simple. The CMT has received almost $2 million in matching funds this year. And I mean, that's just an unbelievable amount going to the work you're about to hear of and many other programs for those of us with CMT. So if you're already given this year, let's make this day count and give a little more. So if you can, please donate today and support all this great work. Now, on to the reason we're all here tonight. Today we're joined by CMTA Board Chairman Gilles Bouchard, who will kick off the webinar by giving an overview of STAR. Then we'll hear from Drs. John Svaren and Kleopas Kleopa, both members of the CMTA Scientific Advisory Board. These world-renowned researchers are going to explain in terms we can all understand what gene therapy is, how it can be used to advance treatments for CMT. And importantly, they will cover in some detail the latest advances from the STAR program that I previously mentioned, including how the CMTA is preparing for clinical trials for many types of CMT. So with that introduction, I'm going to turn this over to Gilles Bouchard and enjoy the evening with everyone else to listen to what they have to share. Gilles, it's all yours.
Thanks, Bob, and good evening, everybody, and thanks for joining us for this webinar. It's a great honor to be here with John and Kleopas. I'm going to give you a brief overview of STAR, and then I'll turn it over to the scientists. So the first thing I want to highlight is, you've heard about STAR before. STAR stands for Strategy to Accelerate Research, and it's really core to the CMTA's mission, and our role is to accelerate treatments for CMT, as you can see in our mission statement here. But the point I want to highlight is we are really driven by the community. Everything I'm going to show you and the scientists are going to discuss tonight is powered by you, the community. I think last I looked, more than 80% of our resources come from the CMT community. So in essence, this is really your program. STAR is for you and by you. And again, big thanks for everybody. This is really something we're very proud of, and we think we should all be very proud of as a community. This is our program, and it's really starting to work very well for us. So when we started STAR, we really wanted to take a business approach. We wanted to bring the rigor, the focus, the accountability that you have in a business. And the first thing when you run a business and you kind of look at your ecosystem and try to figure out your strengths and your weaknesses and try to figure out the best strategy to be successful. So when you look at what it takes to bring drugs to market, and remember, there are no treatments for CMT. There were no treatments 10 years ago. It's a tough business. It's been studied pretty thoroughly, and as you can see, it takes well over 10 years in average to develop a drug. Most of them fail in clinical trials, and it costs hundreds of millions of dollars. So when we look at that, and on top of it, knowing that there were no treatments for CMT, we were wondering, how do we make this attractive to partners? How do we accelerate research? And we found there were actually some strength in CMT. one of the most attractive things about CMT is for most types, we have very well defined genetic causes, what the doctors call it monogenic disease, which means that we can replicate this disease. This is very powerful because it allows scientists and partners to test. So we have assays which are cell levels, and we have animal models, and we'll talk about how much we've developed this over time. And the other thing we're going to talk about today a lot is there are just a lot of new therapies and technologies to address the genetic issues, and those play right into what CMT is as a disease. Now, the third thing, and what was a really big challenge, is most companies and biotechs looked at CMT as a slow evolving disease, and therefore it would be very long and therefore very expensive to run a clinical trial. And if anything, this has been the biggest inhibitor for pharmaceutical companies to get involved in CMT. So more than 10 years ago, and in partnership with the INC, we embarked in a major effort to develop what's called biomarkers, and also to develop an important clinical infrastructure so it would become much easier, faster, cheaper to run clinical trials on CMT. And you'll hear from John that we made tremendous progress there, and this barrier is really starting to crumble, and we see a lot of partners coming to CMT in big part because of the work of the last 10 years in this. And then from a business point of view, what's interesting is you may think that being a rare disease is a disadvantage, but because of the work and some of the laws in the US and in Europe, they've made actually it attractive for companies to work on rare diseases. There are some business advantages on the tax side and protection of IP. So not only are companies interested in working in rare diseases, but it's also very interesting sometimes for a given drug having an indication for a large market, but also for rare diseases like CMT, and we see that playing well into our hand. So that's our ecosystem and how basically everything we've been doing strategically in the CMTA and in STAR for the last 10 years has been driven and has kind of driven the success we're seeing today. So how do you attract partners? I mean, at the core of the strategy is how do we make CMT attractive to partners to come work with us? Because again, even though we've raised a lot of money from this community, we don't have the billions and billions of dollars it takes to develop drugs. So as we work with partners, we found there are really 5 key things they look for. And they'll not all look for all 5 of them, but they'll look for a combination. The first one is what they call KOLs or experts. In general, companies are expert in their drug, but they don't know CMT very well, so they want to engage with CMT experts, and that's why we built this incredibly strong scientific board with over 30 great scientists in it. Now, the next thing they want to be able to test, what we call preclinical tests. So those are tests in the lab, and this is how drugs are being developed. And we spend a lot of time, a lot of investment in the last 10 years building a very broad, very powerful preclinical testing infrastructure where now companies can come in and can test multiple types of CMTs in multiple models that are very representative and they feel very good about. This is, frankly, when they contact us and see what we've developed thanks to your support, they're like kids in a toy store. They say, wow, it's amazing, all the tools you have, and it really makes our life easier. Now, the third one I've talked about is clinical trial readiness. This was a major inhibitor for CMT research and for companies. But again, we made tremendous progress there and still a lot of work to do, but we feel like we are getting clinic ready and we can run much shorter clinical trials. And again, John will talk about this a bit more later. So these are on the medical and science side, but companies also want a strong, reliable, trustworthy business partners. What we found is not all companies are the same. They want different things. So we have to be flexible. We have to adapt how we work with them on the business side based on what they need. Some companies, for example, are early stage companies that need money, so we do co-funding with them. But some companies are loaded with money and they're more looking at licensing or buying technologies that we've developed with our partners. Other companies are looking at raising money, so we help them engage with their potential investors. So on and on and on. So we have a lot of people with business experience on our board, and we really try to leverage this to try to help companies be successful on the business side as well. And last but not least, what's really interesting is companies are really interested in engaging the CMT community. And especially as they get closer to the clinic, that becomes very important for them. And again, they don't do this just out of the goodness of their heart, but because ultimately the CMT community is their market, and they want to know the CMT patients, they want to know the impact that the disease has on the patient community. And what's interesting is engaging patients is becoming very important also as part of the approval process of drugs. In Europe right now, you have to partner with a patient advocacy group to get a drug approved. And in the US, the FDA is doing more and more of the same thing. So the fact that we can reach tens of thousands of CMT patients and we have this really vibrant community is actually a great asset for us and really attractive to our partners. So now you may ask, how is this working? So I just put a few numbers together. We've covered some of those. But again, thanks to your support, we made tremendous progress. And again, we have a lot of work left to do, but we feel like we're in a really strong position right now. We have a wonderful advisory board. We have about 50 active projects, and we've invested, by the end of the year, we'll be at about $15 million in CMT research. We have developed those really helpful testing tools for all major types of CMTs that our companies are using. And as a result, as you can see, we have 25 industry partners. That's a really important metric, the one, if anything, that makes me the most helpful about the future. I mean, a few years ago, we just had a handful of partners, and it was hard to bring them in. And now people approach us all the time because they want to work on CMT, they want to work with us, they want to use our tools and infrastructure. And you can look at this number, this 22 joint preclinical studies. Those are 22 actual studies that people are running this year using our infrastructure. Now, last year, this was only a handful. So in business terms, I think we're seeing a bit of an inflection point, what we call the hockey stick, where you invest and you work hard for a few years, and all of a sudden your business start taking off. And I think that's what we're seeing right now in CMT research, where there's just a lot of things that are starting to accelerate. And again, we're not done. This will still take a lot of time, but it gives a lot of hope that the right things are happening. And then we have this really wonderful, vibrant community, all the branches around the country, the centers of excellence, and this has created a very powerful, helpful infrastructure, not just for us as a community, but also as well for our partners. So thanks again for all this. Okay. Now, before I turn it over to John and Kleopas, when we look at where to invest in STAR, we try to look at leverage points. So there's a lot of areas where we invest that cut across all CMT types or many CMT types. So I already talked about the testing infrastructure that we've developed that cuts across most CMTs. We will cover and go in depth today into gene therapy. We'll cover as well biomarkers. Another one we're not going to cover as much, but it's quite interesting. It's called axon degeneration, where it turns out that a lot of companies are working on ways to prevent nerves from degeneration or degenerating for a broad set of neuropathies. And they want to use CMT as one of the rare disease indications for this. So there's a lot of companies who are working with us now to try to find ways that we can slow down or even stop the damage to nerves with some of their drugs. And then also very important, gene discovery, because you'll hear all the great progress on gene therapy. Obviously, to apply gene therapy, you need to know which genes to fix. So we've really doubled down on trying to find more genes regarding CMT. So this is the overview of what we do across all CMTs. We're going to focus on a couple of them today. Just keep in mind that we won't cover it today, but we have very thorough plans for each major CMT types where you'll find those themes, plus in general 3 or 4 key projects which are specific to this type. So I will stop here and turn over to Dr. Kleopa.
Okay, good evening, everybody. Thank you for joining us tonight. It is really inspiring and a big honor for me to be able to communicate with you and be in touch with the wonderful CMT community. So let's see what is gene therapy, what we're talking about tonight. So gene therapy is the use of genes or gene editing as a treatment. This process involves the introduction of genetic material, for example, DNA or RNA, into cells and tissues of an individual instead of other treatments such as drugs or surgery. There are different types of gene therapy, including replacing a faulty gene. That would be a missing or mutated gene that can be replaced by a healthy copy of the same gene. or inactivating or silencing a mutated gene that has taken a toxic gain of function and is functioning improperly. And finally, editing a part of a mutated toxic gene, which is shown on the diagram here, essentially a cut and paste approach where you selectively cut out a part of the gene and replace it with a healthy part of the gene, which is also the technically more challenging. How does gene therapy actually work? In most cases, we use viral vectors to deliver the therapeutic gene. So these viruses are used as vehicles to package our therapeutic genetic material. They have been modified so that they're not infectious or contagious. They have the ability to enter the cell. Once inside the cell, they will release the genetic material, and that will start the production of the protein, and this will correct the defect in the cell and be treatment for the disease. And here, I should note that this will be a one-off treatment. So once the virus is inside the cell and releases the genetic material, this will stay and keep producing the protein that the cell needs to function. Next slide. So now let's look at the types of CMT so that we can understand how we can apply gene therapy to CMT neuropathies. First of all, nerves are bundles of many nerve fibers, and most of them are wrapped in myelin. They are similar to electrical cables, and you can see the picture on the lower left that are made of many wires, and these wires have a plastic coating. And in nerves, this coating is called myelin. It's an insulating and protective coating that is formed by specialized cells known as Schwann cells. And myelin is very important because it speeds up the conduction along the nerves by 100 times. It's like going from 3G to 4G, but also supports and maintains the nerve fibers. So depending on whether the damage is in the Schwann cells and the myelin, or in the axons, we will have demyelinating types of CMT or axonal types of CMT. In the next slide, you see again in the picture the diagram of a healthy nerve, and you notice that it starts with a cell body. That would be, for example, a motor neuron that is located in the spinal cord in our spine, which sends a long extension all the way to our muscles in the arms or legs. And this is the peripheral nerve. And all along this nerve, you need to have myelin, and this is formed by Schwann cells. So there are over 100 different genes that can cause CMT neuropathies, and they have various functions in the cell, and this results in many different mechanisms. If the mutated genes are mostly expressed in Schwann cells, then you have a demyelinating type of CMT because myelin suffers first, but this will eventually also destroy the axon. And if the mutations are found in neurons, then we will have an axonal type of CMT. In addition, we classify CMT neuropathies by the type of mutation and whether this is a toxic gain of function mechanism or a loss of function. And that will also determine the gene therapy approach. So what are the potential gene therapies we can use for CMT neuropathies? So we have to address the disease mechanism that I described in the previous slide. For CMT neuropathies that are caused by a loss of function of the gene, this is the case with most CMT4 neuropathies and CMT1X, then we have to really replace a healthy copy of the gene. So that's a gene replacement. For CMT neuropathies with a toxic effect of the mutation, and that's usually the case with the CMT1 and CMT2 types, we have to either silence the toxic gene or repair it or modify it so that we can prevent the toxic effect. In addition, we have to deliver this treatment to the particular cell type that really needs the treatment. So for demyelinating CMT, we have to target Schwann cells, and for axonal CMTs, we have to target the neurons. So that means a different approach because these cells are located in different parts of the body.
So this is John Svaren. I am also pleased and honored to be able to serve alongside with Dr. Kleopa on the Scientific Advisory Board for the CMTA. So now that you're all experts on CMT genetics and gene therapy, it's my job to kind of outline the efforts that the CMTA has spearheaded to try to bring new treatments to the clinic. So the science of gene therapy has actually been around for a couple decades, but there are a number of safety issues that had to be dealt with over time. And I think what has generated a lot of excitement is just now in the last couple of years, there are coming now treatments that are FDA approved for different diseases. And the specific example I want to give you is actually a disease known as spinal muscular atrophy. This is actually a motor neuron disease. It actually affects the same neurons that are affected in CMT, but this is actually a devastating disease that affects infants and can have really devastating effects. And until recently, there was really no treatment. But what has been generated a lot of excitement is that there are now 2 new genetic therapies that have been recently approved for spinal muscular atrophy. And this includes AAV gene replacement therapy, just as Kleopas had just outlined, by a company called Avexis. And this diagram on the left kind of summarizes how this therapy works, again, by delivering the correct gene to the motor neurons. And then there's another genetic therapy involving antisense oligonucleotides, which we'll talk about a little bit later. But the good news for SMA is that there were dramatic effects that have been observed with both therapies, as long as they're administered early enough in the disease. So we're not only grateful for these advances for SMA, but it also provides us really an avenue that we can walk down with CMT because, as I mentioned, it affects many of the same cell types affected in CMT. We can really pursue that. So to take advantage of this, we convened just last summer, summer of 2018, a gene therapy for CMT workshop. And this was really for us to really get our plans together and take advantage of a number of different advances. We invited scientists and clinicians that were involved both in spinal muscular atrophy, but there are also parallel efforts in different types of CMT, CMT2D and CMT4J. There's also trials going on for giant axonal neuropathy, or GAN. And essentially, we want to convene this discussion to discuss what was ongoing and also see if we could have a coordinated effort for application of this technology to CMT. And we have a number of assets that Gilles nicely outlined, I think, at the beginning of this webinar. First of all, we had previously funded efforts of Dr. Kleopa to apply gene therapy, and he's going to tell you a little bit more about these specific examples in a minute. And we have also partnered with other companies using ASOs. The animal models that we have developed are very important testing systems for development of gene therapy for CMT. Another aspect that's really not to be neglected is the fact that we need to have good biomarkers and clinical trial planning expertise, which is really enabling for a number of people that want to invest in CMT to do so. And then ultimately, we realized that we needed to recruit some leading gene therapy experts to our scientific advisory board to lend their expertise and their advice as we move forward. These experts include Dr. Kleopa, who you just heard from, who's really pioneered a lot of the development of gene therapy for demyelinating CMT. And then we have 2 additional experts, Stephen Gray at University of Texas Southwestern, and also Scott Harper at Nationwide Children's Hospital. And these are really leaders in the field. Dr. Gray, in particular, is already engaged in efforts for CMT4J and another type of CMT, giant axonal neuropathy, GAN. And really, recruiting these experts has been really instrumental in us being able to plan how we can best use CMTA investments to really accelerate development of new gene therapy treatments. So with their advice, we have formed a plan, essentially, to, number one, to develop a CMTA-sponsored effort to target CMT2 using AAV9-based gene therapy. AAV9 has been used in other FDA-approved treatments, and we decided initially to really focus on the most common form of CMT2, which affects roughly 10% of people with CMT, and this is caused by mutations in the mitofusin 2 gene, and this is classified as CMT2A. Our second objective was really to develop gene therapy for CMT types 1 and 4, particularly the demyelinating forms of CMT. Dr. Kleopa will say more about this in the next several slides, but basically we need to optimize our approaches to improve delivery of the genes to Schwann cells, and we also definitely want to target the most common form of CMT, which is CMT1A, using another kind of technology called RNA interference. And then finally, as Gilles had mentioned, we really want to be able to develop company partnerships that can help us actually bring these therapies to clinic. So on the last point, I think just a year after this workshop, we were really pleased actually that our efforts have really met with some success, particularly in our initiative to develop a new gene therapy for CMT2A. And based on studies of one of our board members, Dr. Robert Balo, we found that there's a way to overcome the mutation in CMT2A, and we formed a partnership with one of the leading companies in the gene therapy space, which is known as Passage Bio. And you probably may be aware of the announcement that came out a while back, where we formed an alliance that will develop and test gene therapy using some of the rat models of CMT2A that were originally sponsored through the CMT Association. This will be a broad collaboration. There'll be collaboration with the Inherited Neuropathy Consortium to sponsor preparations for clinical trials in CMT2A. And ultimately, when the testing is done for safety and everything, hopefully clinical trials can commence when the preclinical studies are complete in consultation with the FDA. And I should mention that we have other efforts on other types of CMT that are in discussion with not only this particular company, but other companies as well. Overall, in our approach, we wanted to really have a comprehensive approach for different types of CMT. And this is sort of a pie chart that represents the different types of CMT, ranging from the most common CMT1A to things that are more rare as well. And this arrow around the pie chart really covers the number of types of CMT that are covered under existing plans or projects, or ones that are under discussion. So I think we're well on our way to covering almost 3/4 of the people affected by CMT with our ongoing projects, and we're hoping that we can expand that in the future. And this includes many different technologies, AAV delivery, and we'll mention more about gene silencing in a minute. And we already talked about some of these technologies, and I'll mention more about antisense oligonucleotides. But I just want to emphasize that this is really a broad spectrum effort to attack many types of CMT, and so we're not really focusing on just one, but trying to leverage success in one type of CMT to achieve success in other types as well. So let me turn it over to Kleopas, and he can tell you a little bit more about his success so far.
Yeah, thank you, John. So having in mind the previous background that I presented for the types of gene therapy, now we have two examples of gene replacement that we have developed for two representative types of demyelinating CMT neuropathies. The first one is the X-linked CMT, which is one of the most common types. It's about 10% of all patients. And this results from a loss of function of a gene that is important for Schwann cells. So our strategy was to design a viral vector to deliver the healthy copy of the connexin gene to Schwann cells. And so with several years of work, we have shown that we can achieve replacement of this gene in Schwann cells. And in the picture on the left, there are examples of an untreated and a treated nerve, and you can see that the myelin structure has improved in the treated nerve. And this translates also into improved function with better muscle power and improvement of the nerve conduction velocity. So this is an initial proof of principle that we can actually achieve a treatment for this type of CMT with gene replacement. In the next slide is the second example. So this is CMT4C. It's a much more rare type of CMT, but very important because if it's representative for all the recessive CMT4 demyelinating neuropathies. So here, like the CMT1X, we designed a vector to replace the mutated gene in Schwann cells. And again, we showed that we can achieve the expression of the gene using this viral vector. You can see on the left the picture of an untreated nerve and a treated nerve on the right side, and you can appreciate the improvement of the myelin structure and better preservation of the nerve fibers. And this again translates into improved motor performance, so the muscle power is improved and the nerve conduction velocities are also faster. So again, providing a proof of principle. Still, we have a long way to go before we can reach the stage of clinical testing. So we have now several lines of activities trying to optimize the tools in order to reach that stage. Four major issues that we're trying to address include, first of all, the finding of the optimal viral vector. We're focusing on vectors that have been already used in clinical trials and selecting the best one to target Schwann cells. We also evaluate the best way of injecting these vectors that will be safe and easy to apply to patients. We want to make sure these vectors have no toxicity, they're safe, and we also want to make sure they can get to the whole nerves around the body, because this is what we need to correct in the demyelinating CMTs. So these issues are really crucial, not only for the two types that I described before, but for all demyelinating CMT neuropathies. So results from this work will be relevant for moving ahead also with other types of demyelinating CMT. We also focus in particular on optimizing the treatment for CMT1X using the new and safer vectors. And we want to show that the treatment can benefit various CMT1X mutations, both before and after the beginning of the neuropathy, which is a very relevant question for patients. And for CMT4C, we also develop a new vector that is safer to deliver the mutated gene and to demonstrate that we can benefit the model. So this work, we hope that will get us closer to clinical testing with the proof of principle that these treatments can work. And I'm very excited also to mention that this work has attracted interest from biotechnology and pharmaceutical companies that are really interested to get involved and help us to develop further this treatment and make it possible to reach the clinical testing. And John will take over for the other CMT types now.
So I think this has been a good summary of the progress that's been made so far, but although there are remaining challenges, I think we have confidence that we can overcome them based on the success that's been achieved. And obviously, success in CMT1X and 4C, as Kleopas mentioned, is actually success for CMT1A. And in fact, we're definitely focusing these efforts as well to apply this technology to CMT1A, which is the most common form of CMT. Now, one of the reasons we have confidence in that success is due to another company collaboration that with Ionis, which uses antisense oligonucleotides. And CMT1A is a little bit different than the other types of CMT since there's not actually a mutation of a single base, but rather having a duplication of the gene so that you have too high levels of PMP22. And the results that were shown and published showed that if you use antisense oligonucleotides to suppress PMP22, we were able to show in two different models of CMT1A that you have a fairly dramatic improvement in the myelination. And this is just one example showing in the C22 model the loss of axons and thinner myelin, but that can be restored with the addition of these antisense oligonucleotides. Now, we continue to work with Ionis to try to perfect and refine and make more potent the antisense oligonucleotides. But this success also made us realize that you can use a related technology known as RNA interference or RNAi to accomplish the same goal, that is to reduce PMP22. So in collaboration then with Kleopas and also Dr. Stephen Gray at UT Southwestern, we've just initiated a project that's really targeting the same technology used for CMT1X and 4C, but now targeting that to a model of CMT1A. And this is a three-part project where we continue to try to address those challenges that Dr. Kleopa mentioned, which is to optimize the delivery to Schwann cells, to develop and optimize the RNA interference for PMP22, and then also trying to make this system as safe as possible by really targeting the suppression to Schwann cells rather than other cell types. So I should just mention that our efforts also include exciting extension to the relatively new technology that many people have read about, which is sometimes referred to as genome editing or CRISPR-Cas9. Many people have read articles about this, and this has generated a lot of excitement in the field because this is actually a way to take mutations and actually fix them. So you really can fix the source of the disease. And this new technology of CRISPR-Cas9 is actually being applied and has entered clinical trials for some types of diseases, particularly for those that can be fixed, for example, in the bloodstream where you can replace blood-generating cells relatively easily. The extension of CRISPR-Cas9 to diseases affecting the nervous system will probably take some more time to do all the safety studies and refine this system. But we are really pleased to announce that we are partnering with one of the leading genome editing groups who has focused on axonal forms of CMT, 2A, 2E, and 2F. And we've also collaborated with a company, Toolgen, which has developed an approach for CMT1A, and they've also reported some positive results in public meetings as well. So this technology, I think, is maybe a few years off beyond the replacement gene therapy, but I think there's been a lot of excitement in this area, and ultimately this will become a technology that will really spur development of novel therapies for CMT. So finally, I wanted to just say that all of these approaches really depend on having good measures that one can use in clinical trials. As Gilles had mentioned, when we talk to companies, they want to know how they can plan a clinical trial in a way that they'll get a definitive answer relatively soon. And this has been a challenge for slowly progressive disease like CMT. But we took this challenge seriously, and we've supported a number of initiatives. Some of them have developed within the context of the Inherited Neuropathy Consortium, which is partially supported by the CMTA. And there's also been direct funding of CMTA of some of these efforts as well. And so there's been tremendous efforts to really look at muscle MRI, which has turned out to be one of the most sensitive measures of progression in CMT. We are looking at proteins and blood samples that can be used to measure neuropathy. We've used skin biopsies to develop other methods. There's been a lot of work in CMT evaluation score development, and we're also investing in wearable devices that can be used in the clinic or even at home to sort of assess balance and movement. And the coordinated use of all of these biomarkers or outcome measures is such that we can hopefully provide companies and investors with relatively quick assessments of whether a clinical trial will be effective. And this is really crucial for those entities to be able to actually provide investment in those. So I think progress in this area is just as important as development of the gene therapy itself. And so I think that's really an important element of how we proceed on all of these gene therapy development efforts for all the types of CMT. So back to you, Gilles, I believe.
Thanks, John. Thanks, Kleopas. Wonderful work. And we've covered a lot of ground in a few minutes here. So I want to just take a minute to kind of wrap it up and kind of share with you how I see all the pieces of the puzzle fitting together. So what we've learned from Kleopas is there are two major type of gene defect, what we call loss of function when the gene stops working, or what the doctors call a toxic gain of function when the gene starts doing something toxic to the body. And then there are three major technologies in gene therapy. We've heard about gene replacement, where you take a virus and send a replacement gene, or gene silencing, where you use technologies like RNA interference to interfere with the protein production, and then gene editing, what's known as CRISPR. Now, the first thing we talked about and we heard from Kleopa is the 1X and the 4C project. Remember, loss of function is usually type 4 and type X. And we got projects for the two most common types, and he showed you the very promising results there. The next thing that John covered is the gene silencing. We have three initiatives there. So the one we've had with Ionis using ASOs, and this new project we just started with three collaborators to use RNA interference in combination with a virus to try to silence the gene in CMT1A. And one third effort we haven't mentioned is this 2D effort in partnership with a wonderful CMT family and also with Nationwide Children's Hospital in Ohio, which has really become one of the top leaders in the world in gene therapy. So three key efforts there. And then just recently as well, you heard and John described the very exciting partnership with Passage Bio, one of the most respected startups in gene therapy. And we're working together with them in 2A. And we also are reviewing right now very interesting projects in 2E. So again, this matrix continues to fill. And then in the gene editing space, John mentioned the very exciting partnerships with what's probably the leading group in gene editing in the world out of UCSF and Berkeley, who really called us and said they wanted to work on CMT and had done some initial tests and wanted to collaborate with us. And again, this is maybe a bit more exploratory, but we think it's tremendous potential. And then also the 1A collaboration with the Korean company, Toolgen. So as you can see, those things really start to fill in all the blanks here, and there's more and more coming. Now, this is really how we develop technologies to fix those gene effects. But as the doctors explained, it's also very important to be able to deliver the therapy to the right cell. So again, two different cells here, the neurons for type 2s, there's general optimism there because it's been done before in SMA, for example. But for Schwann cells, so it would be type 1, X, and type 4, it's a whole different challenge because you have to deliver the therapy to the millions of Schwann cells which are along your nerves. So that's why we have this, I think, very important collaboration with the three scientists here to really optimize delivery to the Schwann cells. And then the last piece, very important as well, is then you have to deliver this to humans and you have to run clinical trials, and it's where biomarkers are so important. We can run fast, efficient clinical trials. And again, when we started, I mean, it was generally thought it would take several years and hundreds, thousands of patients to run a trial on CMT. And now with all this progress, our scientists think we can run clinical trials with just a few patients, less than 100, and in less than a year. So it's tremendous progress and a key factor to attracting partners. So as you can see, we've covered all the ground, but this is not random. We're very strategic about where we invest and where we spend our money, or where we spend your money, your support, so we can move the ball forward. It's how it all fits together. Now, we're not done. There's a lot of work left to do, and that's why it's important to continue to support the STAR program. And there's 5 really key reasons that we look at ourselves when we support STAR. The first one, which I hope you got a taste today, it's an incredibly strong program. It is recognized as the leading CMT research program, and people, the top researchers, the top companies are now calling us to work with us, and nothing could be more exciting for us. Now, the other thing is we take very good care of our financials. If you look at our financials, we keep our overhead very low. 15% or less is our goal, which we've achieved the last 2 years. Most nonprofit tend to spend twice as much in overhead. And part of the reason, by the way, is thanks to you, the community, because most of our resources come from the community. We don't spend too much time, chasing government money or big foundation grants or running major fundraising events, because we get money from you, and that keeps us very efficient and very focused. So you're a big part of that, and that's very important. And by the way, we're recognized for this. If you look at all the independent evaluation agency, we get very, very high ratings, and we continue to improve them so on your behalf. So we're very proud of that. The other point I want to point out, which is very unique to the CMTA, is that the board members, so the people who actually make decisions, are also very invested. I think over 20% of our resources and funding comes from board members themselves, which means that the people in charge are voting with their own dollars. They put their money where their mouth is. And this, again, as I talk to many nonprofits around the country, this is not very common. And again, back to when you evaluate a business, you always want to make sure that the people in charge have a lot of personal stake in it and are really vested. And this is very much the case in our case, and it's very important to us. And then, as you mentioned, because we mentioned earlier, because our strategy is based on partnerships, our partners spend at least 10 times more money than we do when they get involved. So when you support STAR, your money gets multiplied by a huge factor because we attract partners. So all those things together, I think, make it very interesting and very attractive, and that's why we will continue to work very hard on your behalf. Now, we've all come into this for our own reasons, and our involvement is very personal for my wife, Elizabeth, and I. It's this little guy, he's a big guy now, Johan, who has CMT1A, but we all have our own reasons. But at the end, we all have a role to play. I think the message here is please get involved, be part of this. I mean, there's an incredible movement. We're seeing a lot of key success, but I keep emphasizing this is your program. This is a program for you and by you. And I put a few things up there. We have wonderful events around the country, fundraisers. It's really important to be part of the INC and Center of Excellence Network. It will help our research, but it will help you. Because we're more partners, we have launched this Patient Partners Initiative. There's more and more initiatives where you can be involved with companies. As you can see, there's a lot going on, so please sign up for e-news. There's things happening all the time. And where I started working in nonprofit, people said there's really three W's. You can help with work, with wealth, and wisdom. So you can pick 2 or 3 of them, no problem. So with this done, I think I will turn over back to Bob, and a big thank you to everybody. Remember, this is all because of you guys and everybody and the whole community. We're doing this on your behalf, and there's a lot left to do, but we're very proud of where we're at. And now it's time for questions with a few resources on the line here.
Thanks very much, Gilles. Appreciate it. And Dr. Svaren and Dr. Kleopas, that's really fantastic presentation. We do have a few questions that we'd like to get out in front of you guys today. And Dr. Svaren, this first for you. Perhaps you could address this. When do you expect that this gene therapy will be tested in the clinic, and when and how can I participate? Not me personally, but CMT patients in general.
Yes, that's an excellent question. I think it's important to realize that there is an ongoing gene therapy trial for GAN, giant axonal neuropathy, which is a type of CMT. And in addition, as mentioned, Neurogene is sponsoring a trial for CMT4J, which I believe may initiate sometime in 2020. I think the rest of the subtypes of CMT will require further collaboration with the companies. For example, the Passage Bio is initially focusing on CMT2A. Their efforts will require safety testing and testing in animals. And so that is probably a couple of years away. And as I mentioned, we do have parallel efforts to develop similar gene therapy trials. So unfortunately, the answer will be not an answer for everyone, but it'll occur subtype by subtype. And I think you can see from the presentation that Kleopas and others are really engaged in a broad-based attack on multiple types of CMT. So I can only give you a partial answer to that question at this point.
Fair enough. But there's kind of a follow-up to that, and that is there going to be a gene therapy for my particular type of CMT? You went through a lot of the therapies tonight, or a lot of the possibilities. Are they going to be, you're still working on more, or are you focused just on those?
Yeah, I would say based on the work that has been done so far, aside from the other ones that are initiated or should initiate next year, I think we've made significant advances on CMT2A. We're working on CMT4C and 1X, and we've initiated a project on CMT1A. There's additional rare types of CMT that I could mention, but I would say that we are trying to make this technology available to as many types of CMT as possible. And since the technology is somewhat transferable, a success in CMT1X, for example, will be a good sign that we'll also have success for CMT1A, since the delivery issues are the same for those 2 different types of CMT.
Okay. Switching over to Dr. Kleopas. So the question is, how often and how will these treatments be delivered? I gather they're not all the same, right?
Yeah, so it depends on the type of treatment. For example, if we're talking about the viral vector gene therapy, that means that we introduce a live virus in the cell, the genetic material stays in the cell, and that will provide for a long-term expression of the protein that we need. So that would be one-off treatment. Other treatments like the antisense oligonucleotides that John talked about, they have a certain period of time that they stay in the body, so they need to be given at regular intervals. So that's a recurrent treatment. And the way we deliver the gene therapies really has to be applicable in the clinic for people. So that's one of our goals now, to optimize the type of delivery, either through intravenous injection or through injection in the cerebrospinal fluid, what we call intrathecal delivery. So both of these injection routes are well established routinely in clinical care, so easy to apply in the future.
Okay, and kind of a follow-up to that too, Dr. Kleopas. Are these therapies going to be safe, and what kind of side effects, do you guys anticipate from these?
Yeah, so our goal is to develop as safe as possible therapies. So this is the reason why we now focus on vectors that have already been used in people in clinical trials and now also in the market. For example, one of the vectors is the same one used for the spinal muscular atrophy treatment. So they have been extensively studied over many years now, and they have a very good safety profile in terms of not causing any adverse effects. They don't damage the genes of the person where they are introduced, and they also don't cause any significant immunological reactions. So they're considered quite safe. And we keep studying this aspect. This is very important, and it will be also very important before anything can be approved by regulatory authorities. But so far, they look very promising in terms of safety.
All right, thank you. So you did mention SMA, and I know, Gilles, this is for you. The affordability of these therapies going forward, is that something that you can address?
Yeah, interesting question. I think right now there are just a handful of approved drugs, and they are expensive. I think, if we're lucky enough that we get CMT drugs to the market, it will be a few years, and I expect that the technology will have developed. But I still expect that they'll be fairly expensive. To keep in mind, though, is as Dr. Kleopas said, this is a one-time shot. So what's really attractive about the virus-based therapies is you take the treatment only once. So over the life of the patient, it could actually still be reasonable. And it's also why it's very important for the community to get involved, because at the end, it really matters also is how well the insurance companies and the government agencies will reimburse those treatments. And if they really feel like it has an economic benefit that really benefits the patients and the overall cost over time, then it'll be much easier to get better reimbursements. And when I read recently, for SMA, the insurance companies that have issued guidelines all decided to reimburse it with just different kind of constraints. So it's still an evolving space, but I think by the time we get there, there'll be a lot of options for people, hopefully.
All right, thanks. Back to you, Dr. Kleopas, for another question here. What does a CMT treatment mean for the patient? Will a patient get better? I guess there's different qualifications for that.
This is a very important question. So at the end of the day, everybody needs to know what to expect from this kind of treatment. So it really depends on the type of CMT, on the stage of the disease. So if it's early or has been long-standing, and also on the age of the patient. So it's clear from the work we have done experimentally that the earliest you intervene, the more you're likely to have a therapeutic benefit. But equally important is that we have seen improvement even if we intervene late in the disease course. So in any case, we expect that we can achieve a stabilization of the problem, so prevent further deterioration of the muscle weakness. Even in patients who have a lot of weakness in the leg muscles, we can help more central muscles that are very important for function and walking. So even in very advanced disease stages, I think we can achieve a reasonable therapeutic benefit. But the minimum we expect is to stop the progression of the disease and also to expect some improvement in terms of muscle strength, mobility, and sensation.
All right, thank you. And finally, we have one more question here. I guess this would be for you too, Dr. Kleopas. We've heard, someone wrote in, I heard of a single patient trial, and they're curious, why is that? And if successful for the one patient, then, what are the next steps? Like, how do you expand that, I guess?
Yeah, so I mean, there is this type of trials that are really very individualized. So they're targeted towards a very specific gene mutation found in a single patient. So it can vary depending on what this patient has. So if it's a mutation that is very unique, we may not be able to apply the same treatment to other patients with the same type of CMT, but we can still benefit a lot from the whole process of developing it because several tools will be also applicable to other patients with a similar type of CMT. So, and if the mutation is similar to mutations found in other patients, then the treatment could also be directly applicable to other patients. So it depends how individualized the approach is in these single patient studies, but in any case, they can pave the way for treatment for many more patients. So they're really also very important.
All right, thank you very much. And that's really all the questions we have. So I just want to say thank you to Gilles, Dr. Kleopa, Dr. Svaren, everybody listening tonight. Thanks for joining in. I sincerely hope you found this webinar of interest and worth your time. And with that, I'll say good night and have a good evening.